Alright, so here's the final part of the lecture, part 3. Let's talk about some eye injuries. Whenever you examine a patient with a possible eye injury, you definitely have to get a good history of the patient. How was your vision before injury? Did you have 20/20 vision, also known as emmetropia, or you had some nearsightedness, which is also known as myopia, or farsightedness, hyperopia, or hypermetropia, or maybe astigmatism? Presbyopia is a gradual loss of ability to focus on your object, and then it typically is going to affect a little bit older age population. So you may or may not apply to you. Maybe diplopia is a possibility. Double vision. Some other things that you want to think about. Maybe this person has congenital abnormality in their eye, pupil size or shape. So make sure you ask some questions to obtain the history. What was normal for the person? How are you going to check somebody's vision? Well, we typically use something, again, known as Snellen eye chart. It's the standard American one that we use. This is a child one because sometimes the child may not be able to identify alphabets. This is actually what we use in Japan. So what you're going to have to do is you need to identify this opening. You can say right, left, up, or down. When you examine somebody's eye, you also have to think about possible general medical health conditions that can affect somebody's eye. For example, diabetes. It's very common for people with diabetes to develop a complication that is going to affect their retina, and they might have some vision issue there. Listen to the chief complaint. It may not be always, again, pain. They might feel like sense of fullness or pressure in their eyes, or their vision is impaired. They might be experiencing some floaters, increased floating in their eyes, something like that. So listen to the chief complaint. This is what the patient's vision will be like when they have certain conditions. So this is 20/20 vision, emmetropia. You can focus on everything. This is myopia. You can see nearby object fine, but not the far because their lens is too rounded. Hyperopia, if their lens is too flat, they can focus on the far objects, okay, but not near. When they have astigmatism, the lens got all these irregular curvatures here and there, so their light start to really scatter. They don't have focus, so they're having a hard time focusing on really any object, whether it's near or far. Observation, you can actually tell a lot by just simply looking at the person's eye. Maybe global displacement. So this eyeball looking like it's kind of sank down a little bit compared to this one, and when this person starts trying to look up, this eyeball do not move. This would actually indicate the orbital floor fracture. Eyelid, maybe you can catch some infectious formation. This one is a stye, infection of ciliary or sebaceous gland. Sometimes you can see the cornea damage, maybe corneal aberration, nasalization. Sometimes it's very small, sometimes it's really actually visible in the naked eye. This one is something known as hyphema. This is a collection of the blood within the anterior chamber of the eye. This would often indicate a very serious sight-threatening condition, so you probably need to make a referral if you see that. Look at the conjunctiva, which is a very transparent thin layer of the cover of the eye. If you see something really red around the conjunctiva, it might indicate infection or irritation of the conjunctiva, often known as conjunctivitis or pink eye. Sclerella, this is a white part of your eye. Sometimes if you see some discoloration over the sclerella, that might indicate some damage there. Iris is the color of your eye. You might have some infection or redness around that area as well. Pupil size and shape. Again, you need to know what's normal for the patient, but maybe deformity in the pupil has a little kind of a triangular different shape to it. It might also again indicate a significant eye injury, as well as anisocoria, which is the unequal size of the pupil. Some of the injuries that's possible: orbital fracture, that's either blow out or blow up, depending on the name. Sometimes that would indicate a different damage to a different part of the bony orbit. So what you're going to sustain is a nice blunt force or trauma object hitting the eyeball. It's going to create increase in pressure within the bony orbit, and it's going to break typically the most fragile part, orbital floor, more common than anything else. They're going to have some pain around the eye, maybe towards the back of the eye. That might refer down to the mouth area if possible. In some of the cases, they're going to have ecchymosis, swelling, and like the picture that I showed a little bit earlier, their eyeball might look a little kind of sagged down and bulged, or sometimes immediately displaced depending on which part they experience in the fracture. There may or may not be tender upon palpation because the fracture might be happening way down here. So palpating over this area may not elicit anything. They might have diplopia, blurred vision, and also inability to move, typically inability to look up. You should consider immediate referral if you ever suspect this condition. Corneal aberration, lacellations, typically acute. Maybe they got something in their eye and it scratched it, or maybe the contact lens caused this aberration, lacellation. If it's very small, it's not typically very visible, so you need to make a referral, and at doctor's office they need to use specific stain to really visualize the damage. If it's a severe though, you might be able to actually see it, which is typically not a great sign. If you can see, that's pretty massive tear. Even if it's a small corneal aberration, people would often express a severe, intense, sharp pain. They may not be able to open their eye, and it's very common for them to describe it as, "I think I got something in my eye," when in fact they don't really get anything in their eye, just that they got a little bit of a scratch in their eye, but it does look like something else is in their eye. Blurred vision and photophobia, sensitivity to light, is a very common sign of symptoms. Maybe their eyes start to water, their eyes start to get really red. Like I said, if you cannot open their eye and cannot examine, I would say just go ahead and make a referral. If it's a vacillation and very severe, it might require some surgical repair. High femur, like I said, it could indicate something very serious, and the blood accumulation that you see might be just a little bit here, maybe halfway, maybe all the way, depending on the case. Especially if they complain about the trauma, you need to make immediate referral. It's possible for some patient, not very common, but some patient to develop some spontaneous high femur with no episodal trauma. Maybe they're experiencing some kind of intraocular pressure increase due to some other things. But anyways, you need to consider immediate referral if any case you see this kind of a condition. Patient will require to be in almost like a semi-reclined bed rest all the time, so the blood can just sit there. If they start to move, then the blood is going to start to move, start to travel. So you really almost required to be in the kind of like half bed rest. It should typically resolve within a week or so with a conservative treatment, but if it's very severe or maybe some other injury is happening at the same time, it might require a little bit more than just a rest. Retina detachment. Sometimes you can experience a little bit of a tear in the retina, and this fluid that you have inside starts to leak this way and then push the retina away from the wall, and it can facilitate the detachment. Sometimes this injury is caused by repetitive impact to the head, and often maybe boxer can develop this kind of a condition because they get hit in the head a lot, and a little bit of, say, shaking force to the head and to the eyeball can gradually lead to this condition. Or sometimes the patient might have something else like a Marfan syndrome, and if that's the case, then their soft tissue across the body is going to get affected. Their retina is one of them. Their retina is a little bit weaker than other people's retina. So people with Marfan syndrome more likely to develop this kind of complication. This is typically a painless condition, so what they're going to complain is flashes of light in their vision, or sudden increase in floaters, blind spot, maybe they'll see some black spots here and there, heaviness of the eye, and one day they might describe it as a carton fell over my vision, it's not going anywhere, it's kind of blocking my vision. So here's our actual imaging, the internal eye structure imaging of the retina. This is normal, and this one is definitely looking very different, indicating the detached retina. Some other conditions, conjunctivitis. Sometimes this condition could simply be caused by mechanical irritation or allergy, but most commonly bacterial infection. How can you really tell? Well, look at the color. If it's a viral infection or maybe no infection at all, you don't really have much of a discharge, everything is clear. But when you see some yellow or green gooey stuff around the eye, then that would certainly indicate the bacterial infection. This condition is very contagious, especially if it starts to affect one athlete and one team, it's going to spread very quickly. Especially the athlete is swimmer, they're not allowed to go back and pull unless they will become non-contagious taking the medicine for certain days. So you need to make immediate referral. Okay, and sometimes when they're waking up in the morning, their eyelids might stuck and they may not be able to open the eye. They need to take some antibiotics for a couple of days. Foreign object, it might be a very small object, but it'll feel like a brick. Okay. If they're to scratch this area, it can lead to corneal aberration, so that's something that they're never supposed to be doing. Do not rub it, do not scratch it. You're trying to flash it off with a saline solution or water, and make sure that they tilt in their head when they attempt to flash, so the fluid, water, whatever you're using, can actually push the foreign body from towards the corner of the eye. You can use the moistened wetted cotton applicator or corner of gauze to really kind of sweep it off, but you're never supposed to say push or scrape it, because you can actually make this condition worse by applying more pressure to it. Ear structure, you have external ear and middle ear, which is tympanic membrane and 3 bones here, as well as inner ear. Remember we talked about vestibulocochlear nerve? You actually have it right over here. Vestibular nerve is coming from the semicircular canal, which is responsible for balancing. Cochlear nerve is connected to cochlear, which is responsible for hearing. Ear injury, again, ask some questions about the general medical conditions. Sometimes they develop upper respiratory infection and they start to develop some ear infection. So think about some maybe other medical history, some conditions that might lead to ear conditions. Vertigo, nausea, vomiting, that actually might be caused by some balance problem. Okay, so investigate that as well. And also maybe ask them about, okay, what have you done recently? Maybe they've done some diving or airplane travel, which is going to affect some pressure of the ear, and maybe that pressure change led to something else in the ear. People can develop hematoma over the ear, also known as cauliflower ear. Typically acute injury, so you get the blunt force hitting the ear and then you start to experience some massive bleeding within the ear. Well, while the hematoma is accumulating, it's typically very painful. Once everything is done though, it may be very painless. So once it's formed and it's fully coagulated, it's going to start to form some fibrosis, massive fiber formation, and it's going to become more of a permanent scar, keloid formation. So while they're experiencing the massive active bleeding, the best thing you can do is make immediate referral so the doctor can aspirate the blood. Again, if you don't treat right away, it could scar down and it become really hard and it could be permanent. But if you are suspecting this condition, that also means the athlete got hit in the ear. Check for a concussion. Tympanic membrane rupture could be an acute condition. Maybe it's because because of the infection, or maybe because of the pressure change. Maybe they get punched in the ear and then cause sudden increase in pressure of the inner ear or middle ear and led to the rupture. It's most commonly seen in a collision sport and or water polo or diving. You might need to use otoscope to really examine the tympanic membrane, and that examination might reveal something like this is kind of a little bit bigger tympanic membrane rupture. If it's small, it's going to heal by itself. Most of the cases, it's not a big deal. You need to watch for infection though, because the bacteria can find a way to get through and then get sent and maybe start to cause some infection, so you need to be careful with that. If it's a medium massive tear, it might lead to more of a long-term or almost permanent hearing loss, because it might scar down a lot, so you need to make a referral. The last condition I have here is infection of the ear, if that's external ear or more of a middle ear. Okay, external ear infection is very common among swimmers because their ear is always wet, and then bacteria like the environment of dark and then moist. So practicing a good hygiene is going to be very important. But if you start to suspect otitis externa, you can actually visibly see the infection. The good news is it's right affecting the external ear, so it's right there. You might be able to see some nice discharge coming out of the ear. Otitis media, this is a middle ear infection, so you may not be able to see anything over the outer ear, but if you were to perform some otoscopic examination, the tympanic membrane might look really red and swollen. Now, this might be just caused by simple infection, or maybe secondary to upper respiratory infection, or maybe they actually sustained a tympanic membrane rupture first and then led to infection. So anything like that nature is a possibility. All they need to do though is just get in the eardrop, use antibacterial therapy for a couple days, and everything should go away. But during that treatment time, the ear travel is not going to be recommended because of the pressure change, and it might affect the tympanic membrane middle ear area a little bit. So here's a quick review of what we talked in this chapter. I will see you on Monday for the lecture.